recording the audience. Yes. Ah, my finger.
Alright. Second time. Okay.
7 people.
Basic EKG interpretation. What you think of this rhythm? It's bad.
Right.
Obviously. Okay.
Deja vu.
So,
Shut up.
yeah, deja vu. So, here we go through this again. Alright. Alright, to break it down of the EKG, you've got your P waves, QRS, and QRS complex, and T waves. So, P waves are the contraction of the atria. Everyone knows how a normal heart works. Atria contracts, ventricles contracts. It's just constantly like this. Alright, so P waves, the normal P waves you'll see, just a little bump on the EKG. And your QRS complex, it's the contraction of the ventricles, and then your T wave is the feeling of the ventricles. The most common rhythm you'll see is normal sinus rhythm, which is this one. We go pass that one around again. Alright.
Wait, again? Are we doing this a second time?
Yes, we're doing this a second time. Alright. P waves. P waves are always seen in a normal sinus rhythm unless you see a rhythm called atrial fibrillation or else a fib, which is the second most common rhythm. Second EKG strip. Passing that one around. Alright. It is not dangerous to not have a P wave because with atrial fibrillation it's controlled by medication. What your atria is doing is quivering on top of the ventricles, and the ventricles are contracting. You will still see a QRS complex in a fib. With a fib, the only thing different is that there will be a wavy baseline. Sometimes you'll see major waves in the baseline. Sometimes it'll just look like a normal sinus rhythm without a P wave or a P wave. It's weird like that. QRS complex. You need to have a QRS complex to live. Without a QRS complex, you are either close to death or you are dead. They're black and white. There is no gray area. You are close to death or you are dead. Person here was actually my patient. He was in ventricular tachycardia, VTAC for short. What happened was he called because his blood pressure machine wasn't working. He wanted his blood pressure taken by EMS. We put him on the monitor and we found this rhythm, ventricular tachycardia, and pretty much had to convince him to go to the hospital, even though he didn't really want to go. We're not allowed to kidnap people, but we can try and convince him to go to the hospital. Ventricular fibrillation, which is what this is the ventricles pretty much just quivering, the atria along with it, and the only thing that's going to fix that is electrical therapy, medication, and CPR. A lot of times what you guys will see if people are in a VFib for 20 minutes or more, you will see a systole, which is what everybody knows as flatline. It is very difficult to bring people back from this, and a lot of times we don't. That's just it. We really don't bring people back from asystole. We can try, but it's very, very uncommon that we actually get somebody back.
Is asystole an abbreviation for something?
Asystole is the technical term for flatline.
Okay.
So people know it as flatline because that's what they see it in, like Grey's Anatomy. Yeah.
Yeah. Okay.
You see it like that.
I love Grey's Anatomy.
Yeah. All right. Pre-hospital treatment for VFib or VTAC, drive faster to the hospital. The hospital has the definitive treatment for VTAC or VFib. We can only treat the rhythm itself. VFib, treat with medicine. If it's stable, VFib is treated with CPR, electrical therapy, or medication. VTAC, whether it is a stable patient like the patient that I had on the slide before this, he didn't have any chest pain, any shortness of breath, altered mental status, low blood pressure, or pulmonary edema. Pulmonary edema is the fluid building up in your lungs. He didn't have any of that. He actually didn't even want to go to the hospital. So That's why we had to convince him to go. People in VFib really don't have a choice because they're dead and it goes under implied consent. So, pre-hospital treatment for any type of heart rhythm that's other than normal is drive faster to the hospital, and if we have a medication to give you, then we get it. T-waves. T-waves are seen in every EKG rhythm unless you have AFib. With AFib, the baseline is so wavy that you won't always see a T-wave. If you do, it's very rare. If you even see a P-wave, it's very rare. Atrias are always just quivering. It's not dangerous to not see a T-wave. It really doesn't matter. It's just the refilling of the ventricles. It happens. If the ventricles don't refill, then you go back to you're either dead or close to dying. So the most often we see with T-waves when we deal with it is in heart attacks. You see ST elevation. With ST elevation, it'll show us whether a patient is having a heart attack. ST depression is ischemia. It's showing that the heart is lacking oxygen and very close to having a heart attack. So ST elevation, you'll see here, is you've got your P wave, QRS complex, and then you see the mountain of a T wave, and then goes back to baseline. The T wave, when you go to the QRS complex, should always come back down to baseline before it shows the T wave. It doesn't do that when you're having a heart attack because the heart is trying to work so hard to pump blood to the affected artery. So
that'd be bad.
yes, it's very bad. So when you're having a heart attack, when we look at on the EKG, is depression in opposite leads and elevation in the leads that you're having a heart attack in. What's shown here is an anterior ST elevation and myocardial infarction. Pretty much an ST elevation heart attack. What you see here is when I look at it, I see 2, 3, and AVF. 2 and 3 and AVF all have ST depression in it. If you look at the P wave, it's at the normal baseline. If you look just below that, you'll see depression. You look to 1 and AVL, they both have elevation.
That means the heart's sad, right?
It means the heart's having a heart attack and you need to get to the hospital.
So it's
This is sad. You look at 1, V1, there is no elevation, barely any. 2, there's little. 3, there's a little more. 4, there is much more elevation. 5, a little bit. And 6, not so much. What we look at when we are looking at the heart, we normally put people on a monitor. You're looking at V2, which is this one. This is just the 4 leads that go right arm, left leg, right leg. And all you see is this lead 2 right here. That will not tell you whether the patient's having a heart attack. If the patient's having chest pain or whatnot, you will put more leads on their chest, which go 1, 2 through 6 around their pec. It will give you this whole big screen right here.
a more accurate reading.
Yes, a more accurate reading of the heart. A better picture, if you will. That's what we tell patients, is that when we put in these electrodes on their chest, is that we're taking a better picture of your heart. So it's not to alarm them that they're having a heart attack, but in most cases it's drive faster to the hospital. Alright, so you have your P waves. You see in all rhythms except for atrial fibrillation. QRS complex, which you see in every single EKG rhythm unless you're dead or very close to dying. And T waves, which really doesn't matter if you see them, but it's the filling of the ventricles. And you should see them, but if you don't, it's not a big deal. We're excited. A paramedic book, my 12-lead book, and an online source.
Show the audience.
Watch the. Does anybody have any questions?
I got a question about HIPAA. Sorry.
Do you really have a question about HIPAA? Okay. Alright. Do you have a question, Taylor?
I did, but I forgot.
Okay. Does anybody have any questions?
No. Great speech.
No.
Well,
Cool.
Woo!